My name is Erin Sullivan DiMartino, and I am an ethics researcher and assistant professor of pulmonary and critical care medicine at Mayo Clinic in Rochester, Minnesota. I am pleased to discuss a manuscript resulting from collaboration between ethicists, cardiologists, palliative care physicians, and cardiovascular surgeons at Mayo Clinic in Rochester, Mayo Clinic, Arizona, and at the McLean Center for Clinical Medical Ethics at the University of Chicago. Our paper, An Ethical Analysis of Withdrawing Total Artificial Heart Support, will be published in the next issue of Mayo Clinic Proceedings. Replacing the function of an ailing heart with a mechanical device was first imagined by Leonardo da Vinci, but eluded scientists for centuries, actually until 1969. 400,000 Americans die annually of heart failure, and yet less than 3,000 heart transplants are performed each year. Mechanical circulatory support devices, such as the total artificial heart, offer hope to patients awaiting transplant and are now under investigation as destination therapy. The total artificial heart sits in the chest, flanked by the lungs, in the cavity once occupied by the native heart. Percutaneous drive lines, powered by an external compressor, pneumatically propel the blood in unidirectional flow through two artificial ventricles in a pulsatile manner. We know that approximately 1 in 5 total artificial heart patients does not survive to transplant, but until this paper, the experience of patients dying with total artificial heart had not been described. We examined the total artificial heart cohort from Mayo Clinic, 47 patients, and focused on the 14 patients who died with total artificial heart. In 13 cases, a surrogate decision maker requested the withdrawal of life-sustaining therapy, and in one case, the patient himself had decisional capacity and requested that life-sustaining therapy be discontinued. Providers carried out all requests to withdraw total artificial heart support. We found that at the time of these requests, all patients were in moribund condition, supported by multiple other forms of life-sustaining therapy. 6 patients had an advance directive, 2 of which had been completed after the total artificial heart implant, though none specifically addressed the device. Chaplaincy was consulted for all cases. Palliative care was involved in 7, and there was 1 ethics consult. Legal and ethics scholars have established the permissibility of withdrawing life-sustaining therapies that have become more burdensome than beneficial in the eyes of the patient, even extending this to patients lacking decisional capacity whose requests may be exercised through a surrogate decision maker. In our ethical analysis, we demonstrate that there is no distinguishing aspect of the total artificial heart that exempts it from this well-established principle. We consider its location within the body, and that it is a long-term, continuous, and constitutive, meaning it assumes a function that the body can no longer independently perform, form of therapy. We distinguish total artificial heart from true replacement therapies, which become part of the individual as a unified whole and are responsive to the physiological state of the individual, do not derive power from an external source, or rely upon expert control. A true replacement therapy would be an allogeneic heart transplant. We address conscientious objection and refute concerns that discontinuing total artificial heart support would be analogous to physician-assisted suicide or euthanasia. I hope you enjoy learning more about the history, ethical considerations, and experience of patients supported by this fascinating technology. Thank you.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.